Hello everybody and welcome to PathoLogic. Today we're going to be discussing hypoadrenocorticism in veterinary species. Hypoadrenocorticism is also referred to as Addison disease. It results from immune-mediated destruction of the adrenal cortex. In some cases, it can also occur secondary to treatment for hyperadrenocorticism if drugs like trilostane or mitotane are used. Immune-mediated hypoadrenocorticism most commonly affects young to middle-aged dogs, and there are some notable breed predispositions like standard poodles and Nova Scotia duck-tolling retrievers. Addison disease is often called the Great Pretender because its clinical signs are vague and can mimic many other conditions. Clinical signs you may notice include vomiting, diarrhea, weight loss, loss of appetite, and lethargy. However, most dogs with Addison disease present to the vet clinic for the first time in an Addisonian crisis. This is a life-threatening condition associated with hypoadrenocorticism. Features of this condition include hypovolemia and hypotension, hyperkalemia with bradycardia, hypoglycemia, azotemia, and hemorrhagic diarrhea and vomiting. The fundamental principle behind Addison disease is immune-mediated destruction of all layers of the adrenal cortex. These layers are the zona glomerulosa, which produces mineralocorticoids, the zona fasciculata, which produces glucocorticoids, and the zona reticularis, which produces androgens. Of these, the loss of mineralocorticoids and glucocorticoids are the most significant to the animal. We primarily think of aldosterone as the main mineralocorticoid and cortisol as the main glucocorticoid. Some patients with hypoadrenocorticism do not have changes to their serum electrolytes, which is considered to be a common feature of this disease. These cases are often called atypical Addison disease, and they were originally thought to occur due to the disease only affecting glucocorticoid production. However, newer studies show that aldosterone levels are still affected in these animals, and that their renin-angiotensin-aldosterone pathway somehow is able to compensate to maintain appropriate electrolyte levels. So the bottom line is that there will always be immune-mediated destruction of all three layers of the adrenal cortex. However, we may only see glucocorticoid-associated changes in some animals. So to look deeper into this disease, we are going to look at the consequences of low cortisol and low aldosterone. We will start with cortisol. Normal cortisol release is initiated in the hypothalamus, which releases corticotropin-releasing hormone. This hormone acts on the anterior pituitary. The anterior pituitary then secretes adrenocorticotrophic hormone, which acts on the adrenal cortex. In response, the adrenal cortex releases cortisol. In Addison disease, there is immune-mediated destruction of the adrenal cortex. The lack of adrenocortical tissue thus reduces the amount of cortisol that the adrenals can produce. There are several consequences of low blood cortisol. First, we will look at the vascular changes. Cortisol can act on the vasculature in several ways, including activating the release of vasoactive substances, sensitizing the blood vessels to catecholamines, and reducing vascular permeability. Therefore, when cortisol is low, there is a decrease in blood pressure and an increase in vascular permeability. This may lead to the hemorrhagic diarrhea and vomiting characteristic of an Addisonian crisis, as the decrease in gastrointestinal perfusion and lack of prostaglandin production from lack of cortisol may result in gastrointestinal ulcers. Addison disease also results in electrolyte changes. These changes are primarily associated with lack of aldosterone, although hyponatremia can also develop due to a lack of cortisol. This is because cortisol normally has an inhibitory effect on antidiuretic hormone, which is the hormone that stimulates water reabsorption from the urine. Without cortisol, ADH is uninhibited, resulting in increased water reabsorption. The increased fluid in the bloodstream dilutes out available sodium, resulting in hyponatremia. Animals with hyponatremia can present with polyuria and polydipsia. This is because the kidneys rely on a large amount of sodium within their tissue to help reabsorb water. When hyponatremia develops, the kidney undergoes a process called solute washout, or removal of sodium from the renal tissue. This eliminates the concentration gradient for water reabsorption. Ultimately, this leads to increased fluid excretion and polyuria. This dehydrates the animal, leading to polydipsia as they attempt to rebalance their fluid levels. There are a couple other clinical findings associated with low cortisol in these patients. Hypoglycemia arises because low cortisol decreases gluconeogenesis and increases glucose use. These patients may also have a normal lymphocyte count. This is important because patients presenting in an Addisonian crisis are highly stressed, so they should normally have a stress leukogram, which includes low lymphocytes. However, because these animals don't have enough cortisol, their body cannot respond to stress normally, and thus they don't produce a stress leukogram like you might expect. Now we will look at low aldosterone. The normal function of aldosterone is to promote reabsorption of water, chloride, and sodium in the distal tubules of the kidney. It also promotes excretion of potassium. In Addison disease, aldosterone is not produced or is produced in low levels. This results in loss of water, sodium, and chloride, and retention of potassium. Consequently, this produces a hyponatremia, hypochloremia, and hyperkalemia. The combination of electrolyte disturbances from the lack of aldosterone can cause muscle weakness and cramping, and bradycardia due to the hyperkalemia. Aldosterone loss can also promote hydrogen reabsorption within the kidneys, leading to a metabolic acidosis. The metabolic acidosis can further exacerbate hyperkalemia by causing movement of potassium out of the cells into the bloodstream. Aldosterone also has a minor role in absorption of sodium, chloride, and water in the intestines. Without its effect, water stays within the intestine, leading to diarrhea. Sodium and chloride can also draw more water out from the body into the intestinal lumen due to their osmotic effect. This leads us to our final consequence of Addison disease to discuss, which is hypovolemia. This is a very common finding in animals with Addisonian crisis. It results from a combination of factors, including fluid loss from vomiting and diarrhea, lack of aldosterone to stimulate water reabsorption, and inadequate fluid reabsorption due to solute washout in the kidneys. Ultimately, this results in azotemia, as the kidneys are no longer perfused properly due to the low blood volume. This prevents appropriate filtration of waste products like urea and creatinine in the glomeruli, leading to those products accumulating in the bloodstream. Now we will briefly talk a bit about diagnosis and treatment. The main test we use for diagnosing Addison disease is the ACTH stimulation test. Based on the normal cortisol pathway, administering ACTH should increase cortisol production. So to perform this test, you measure serum cortisol levels before and after administering a dose of ACTH. If there is no increase in cortisol levels, then the patient likely has hypoadrenocorticism. As an aside, it is important to note that all glucocorticoids except for dexamethasone will affect cortisol measurement in this test. Therefore, you should not give other glucocorticoids for at least 24 hours before performing an ACTH stim test. Emergency treatment for this condition focuses on correcting the hypovolemia, hypoglycemia, and electrolyte imbalances. Once the patient is stable, they will require long-term treatment by supplementing their glucocorticoid and mineralocorticoid levels. For glucocorticoids, prednisone or prednisolone that has been tapered to the lowest dose is used, with increased dosing of these medications during periods of stress, like transport or going to the veterinarian. DOCP or fludrocortisone acetate are used as mineralocorticoid replacements. Some patients are successful on fludrocortisone only, as it has some glucocorticoid activity. So in summary, hypoadrenocorticism most commonly affects middle-aged dogs. It results from immune-mediated destruction of the adrenal cortex. Its clinical signs can be vague and mimic other disorders. Many patients present in Addisonian crisis, which can be life-threatening due to hypovolemia and hyperkalemia. You can diagnose this condition through ACTH stimulation testing, and treatment involves long-term glucocorticoids and mineralocorticoids. Thank you for watching PathoLogic. If you enjoyed this video, remember to like, subscribe, and share with your classmates. Thanks again for watching, and we will see you in the next video.